Okay, we are now live. So happy Friday, Web Shatters. Thank you all for attending our session this afternoon. Today, we have the pleasure of hosting Dr. Watchmaker, who will be teaching us about interventional radiology. As always, please remember that the Google form will be posted in the chat box at the end of the live stream, and it will be in the description of the video as well. So with that being said, Dr. Watchmaker, you may start whenever you're ready.
Hi, everyone. Thanks for being here. Let me pull up my YouTube here so I can see the questions. Actually, I'm not sure I see the questions, so I'll just look at the chat here. Thanks so much for being here. I am an interventional radiology resident at Mount Sinai. I'm in my PGY 2 year. I did a year of general surgery last year, and I'm just going to start on in and take you on a radiology shadowing experience with a focus on interventional radiology. So the goals of my talk are the following. I'm going to give you a brief introduction to what interventional radiology is. We'll do a day in the life with case presentations and a brief moment about my journey into medicine and radiology, what radiology looks like after training. And really my main goal is to convince at least one of you to consider a career in radiology and more specifically interventional radiology. Maybe I won't try to pull up this YouTube live. Anyway. So what is interventional radiology? Has anyone heard of this? This will be a good time to practice to see if we can get, if you guys like, has anyone heard of it? I'm checking the YouTube live comments right now. Okay, I see. All right, we're live. Okay, so I'll tell you. So it's a medical specialty that involves performing a range of imaging procedures to obtain images inside the body. So interventional radiologist takes these images, interprets these images, can diagnose people based on these images, and then can perform a range of interventions to either better evaluate or treat these conditions. So the difference between radiology and interventional radiology, I'm going to keep this broad, but essentially all interventional radiologists are radiologists first. So the way I think of the difference between the two is that radiologists find the problems early by interpreting the results of the imaging studies and correlating medical image findings with what they see in the clinic, what they see in lab tests. Interventional radiologists also interpret all of those dynamic components when these patients, arrive and have a multitude of various tests, and then they go on to use minimally invasive image guided procedures to diagnose and treat diseases. And you can definitely do both in your career, and you become board certified in both diagnostic and interventional radiology. So a lot of people ask, interventional radiology and surgery, like what should you do? Should you consider IR, or are you more of a surgeon? And we really work so closely with one another. And the way I see it is that the primary difference between IR and surgery is that interventional radiologists routinely use advanced imaging to guide intervention. So here I have an image here. Does anyone know what this image is? An apology. So I see that we're live
with one another, and the way I see it is that the primary difference.
Got it. I see all these responses now. Thank you. Is it the same field as surgical radiology? We'll get to that later. Great. And someone commented that this is a competitive field to get into, and that's true, and I'll get to that later, but that shouldn't deter you at all. So I know there's a little bit of a delay, but this one here on the left, see if anyone, this is an ultrasound image. I wasn't asking necessarily what we're looking at, but this is an ultrasound image, and this very straight line is most likely a needle. Then this is a CT image. So we use, CT scanners are used to just, perform routine imaging, but then you can actually take patients in and out of these CT scanners and specifically target lesions or locations or pathology that you want using that CT scanner dynamically. And then this is a 3D reconstruction of a kidney intervention, and that's something we also do in interventional radiology. So I'm going to take you in the day of the life. I hope this is fun. So we're a clinical specialty, as I said. So 6:30 a.m. we'll get up and we'll round on patients. We, although we don't necessarily have patients who are on our service all of the time, meaning they are primarily a medicine patient or a surgery patient. I see Katie Din, you got ultrasound. Yep, that's right. And then the kidney. Yep, you guys have got this. But anyway, we work with these teams to perform interventions on patients and to evaluate if these interventions are indicated on these patients. Does that CT image have a contrast agent? So I'll slow down so I can keep up with these questions. That one most likely didn't, but I'll get to some more cool imaging with contrast in a second. So after we round on our patients, and those are most likely patients that we've done our procedure on recently who are still hospitalized, we do didactics and case conference. So interventional radiology is really, a very specific field. So it's not something that you necessarily are going to see a lot of in medical school. You'd really have to seek out experiences in interventional radiology to have an appreciation for kind of how they spend their days and the various procedures that you do. So given that, when we become a resident in interventional radiology, there's a lot of didactics and case conferences to familiarize ourselves with, the very broad scope of the practice. So these, didactics are lectures from attendings. I often will present cases that I performed that, hopefully had a good, sometimes had a bad outcome, a complication, and we discuss exactly what we maybe could have done differently. We talk about something called morbidity and mortality. This is not unique to IR in any way. This is something that we talk about in every other specialty when there's a outcome that we didn't expect. And we also, work a lot on public speaking. I hope I'm doing okay today, but, in the clinical sense, there's a lot of, very detailed interventions that go on, and we really kind of go through cases and really analyze what we did as trainees. And it's a really, really fun thing to do. And Jungla, I'll just stop and answer this. What do you mean by a clinical specialty? So I want to say that a lot of people think of radiology as someone who just reads images, sits in a basement, goes through studies. An interventional radiologist, let's say they think of, oh, this team requested this intervention. Okay, you go do the intervention and then you leave that patient. That's definitely not how it is, and not how it's going to be moving forward. Really, I would say both radiologists and interventional radiologists have a lot of interaction with the teams upstairs, because we're usually in the basement taking care of these patients. And as interventional radiologists actually performing, small, you can think of them as surgeries on these patients, and they're often not small, they're just through a small incision. We are very much involved in their clinical course in the hospital. You could contrast that with something like a specialty where you wouldn't necessarily see patients day to day. And what are didactics? Good question. So didactics just means someone's like teaching you something. So, we have experts on all different things, on all different types of interventions, from the brain down to, let's say, the toes, peripheral arterial disease and, atherosclerosis, if you've heard of that, that affects your whole body. And there's people who specialize in the treatment of, let's say, pathology or below the knee. And there's people that specialize in everything that goes on in the brain. And I'll show you some cases involving those types of interventions. But all didactics means is you get someone who's specialized in an area speaking on a topic. Okay, I think I am caught up on questions. So case one of the day. So this probably looks insane, but does anyone have any idea what we could be looking at here? I'll wait for some answers or some questions. I see some people coming in. I know we're on YouTube Live and it takes a second. So I'll get started going through this as to not delay. So essentially we have a cut through a human body like this. It's a CT scan. And really what I want you to appreciate in this CT scan is, you have vessels that run through your whole body, okay? And this is actually, yeah, exactly. Torso, abdomen, yeah, we're seeing all of that right here, exactly. I see Sarah and Jung, CT of the abdomen, great. So I see Tim, you're on it because you have the, modality correct. This is in fact a CT, not an MRI, not an X-ray, not an ultrasound. And then there's people that specialize in everything that goes on in the brain. And I'll show you some cases involving those types of interventions. So Yeah, and someone guessed kidney stones, and that's not exactly what I'm going to be talking about today, but kidney stones show, sometimes will show up as very bright little dots that then cause your kidney problems. And there's definitely a lot of, bright areas in this abdomen. Intestine as well. There's definitely a lot of intestine, and you can see this area is probably stool mixed with air as it's getting ready to kind of come out of you. But what I wanted to show you here is this right here is a stent, okay? And this is a tool we use a lot in interventional radiology. And to answer one of the questions from before, this would be a study that has contrast. So this is something that goes into your vein, circulates throughout your body, and it lights up your vasculature. It lights up, your organs once the blood reaches those organs and perfuses those organs. And what you have here in the middle of your whole body is a clot, okay? And this clot can cause problems. And this is a clot in the vein. And if you think about it, blood's flowing back to your heart. It's trying to go there, but there's a clot. And so you have to do something about that. You often have to do something about that. And that's something that interventional radiologists specialize in. So does anyone know maybe how we would approach this problem? Keeping in mind that I'm talking about interventional radiology. So a little bit of a delay, but I'll just keep going and we'll, so essentially, how we do this is we go through a vein, we access the veins. How do you know it's a clot? Good question. So it's a clot because you can see that there's contrast that's bright around it. And you see this dark area here, and that dark area, means that there's not contrast. So if you think of like a, any kind of, stone in a river, let's say, and the river is your contrast and the contrast is going, you're not going to get that contrast. You're not going to get that, river going through that stone. And what that shows up on a CT scan is something that's darker than the fluid around it. And that contrast is bright on imaging. Yeah, so yeah, these are all great. Cath, whoever John Romero is onto that, right? So, that saying you're going to cath a patient is definitely something we do. And to be more specific here, we're going to go into the venous system. You can do arterial catheterizations and venous catheterizations. And this clot is located in the inferior vena cava. I see Brianna asked. So the IVC is the biggest vein in your body, and it takes most of the blood, the blood from your legs and other parts of your body, and it takes it through the body back to the heart, the deoxygenated blood, so that it can, go through the lungs and go back out. Go through the leg, maybe a central line. Yeah, so you could access this definitely through the leg. Sometimes you could access it through the neck. You have veins that are all connected through a system. And I think that's personally one of the coolest things about interventional radiology. You can even go in through the wrist, okay, and take an artery and use catheters and wires. And I'll show you some examples of those later. And access, for example, the liver through your wrist. I think it's really cool. And this would be considered a clot in your deep vein. So I see Jung Lee is on to me. And clot dissolving drug with catheter. Yeah, that's exactly right. So who is this? Amara Talib. You should maybe go into interventional radiology. So this is, so that's exactly right. So there's a lot of mechanical and pharmacologic. So all that means is there's different ways of going in there with a catheter and either sucking out that clot or mashing up that clot, then sucking up that clot, or you can, stent and open up that area, all things that help you get rid of this. So I'll keep going in the interest of time. So this is, this is the venogram, okay? So blood's flowing forward through your catheter. And here, so this, you can see that, there's a stent here, and then there's nothing that's able to flow centrally from this side, right? So here you have an injection, okay, through where they accessed, and then you go up and there's really a paucity of anything that looks like a vein up here coming from this side. And so what you can do is you can take a little balloon. It's actually not that, a balloon, and you balloon it open. So that would be a mechanical way of disrupting that clot that is going to cause you a lot of problems. And does this patient have a left hip replacement? Let's see. Not necessarily. It's good that you called that left. I think that bone might just be pretty bright. And this is just contrast pooling in the bladder. So that means they've been giving contrast and it's excreted through your kidneys into the bladder. So here you have a balloon and you're opening up that clot, and you're essentially making it so that the blood has a free way of flowing back to the heart. And here we go. So I hope in a very general sense, you can appreciate the fact that when you inject contrast down here in the leg, so this is, you can make out a hip right here. And so I think this is just his native hip. And you put in this contrast. So on these types of images, contrast is dark and it flows up. And then you can see you have good flow into the central veins of your body. Let's see, I'm getting more questions. Yeah, so you're asking about clot dissolving drugs. So someone mentioned warfarin. So we use something called TPA. It's something tissue plasminogen activator. So it's a drug that they use in stroke as well. That it actually has an active site that binds an area of the clot and starts dissolving the clot. So it's something that in biochemistry classes you probably will come across. The mechanism of this, and that's something that we absolutely has been shown in clinical trials to help in multiple settings, and that we do in that we use in interventional radiology. And this is just an example. I didn't really get into the the clinical presentation of this patient, and I apologize. But as you can imagine, when you have a clot that's prohibiting the blood from returning back to your heart, your legs can get very swollen. And what that swelling is a backup of blood and everything that comes along with that, the surrounding edema that causes legs to be very swollen. So this is just an example I got, from the internet, not a personal patient, but I can tell you it's not uncommon for patients to have 1 or 2 very swollen legs. And the root of that is a clot in their vein. So you actually do wonders in terms of not only quality of life, in terms of ameliorating the swelling, but it also prevents them from getting a something called a pulmonary embolism. I'll get to that later, but in brief, the clot can dislodge and travel to your lungs, and that can be catastrophic. I'll keep going. Oh, there's so many of you. There's 267. That's amazing. Okay, so that was a case, let's say, that you finish and then your pager goes off and let's see here, my YouTube live is acting up, just a second. Okay, here we go. Okay, super interesting. Thank you, Zoe. I really appreciate it. And varicose veins, to answer your question, varicose veins are part of the superficial system, okay? They're not part of the deep system. So that's a whole nother, they can go together, but that's a whole nother kind of area that we also treat in interventional radiology. Okay, so can the balloon procedure go wrong? I would say any procedure can go wrong, but yes. So, popping a balloon in and of itself isn't always that big of a deal. But yes, if you balloon in an area, let's say where it's very tight, and you try to open it up, and that vessel doesn't like that, and that vessel is very, very rigid, and the vessel bursts, that can understandably be a problem, because now you have a hole in your vasculature in the middle of your body, and you either have arterial or venous blood that's could be leaving the vascular system and causing hemorrhage. Love the pager, thank you. Have you ever treated a coronavirus patient that suffered a blood clot? Okay, Rita, that's a very good question. And the answer is yes. As you may or may not have read, there's a lot of data that now supports the coronavirus, and it's not just coronavirus. There's many other diseases that predispose you to having clotting disorders. So if you, the short answer is yes. And part of clotting disorders are clots in your legs that can travel to your heart and then out to your lungs. And we treat those in a way by sucking, similar to how you would maybe remove them from the legs, we remove them from the lungs. And I actually have a case of that coming right up. And how does the differential diagnosis differ if a patient has unilateral edema instead of bilateral? These are all amazing questions. So that's a really, really good question, Jungli. So it does change the differential, right? So there's things like heart failure, or if you have malnutrition, or for some reason your blood is not full of the normal proteins, and you do something called third spacing, and you have a lot of edema in your subcutaneous tissues of your legs, that can be a process that is entirely independent from having a clot in your venous system. So actually having one leg that's swollen, not two, is actually, I believe, more predictive of having a clot, in that, there's your IVC, and there's other veins, that you have mirrored on each leg. And if only one is swollen, that's actually, a sign that there could be a clot on that side, that leg, that's causing issues, and not the other side. Whereas if you have something like heart failure and your body's not pumping fluid around as well as it should, and it's backing up and it's causing edema, you would expect that to accumulate bilaterally and more symmetrically. That's a really good question. How often are PAs in the radiology specialty? We'll talk about that at the end, but we work all the time with PAs. We adore the PA that works with us here at Mount Sinai. She does a lot of procedures as well. So you can be procedural, you can be also, more, attend office hours and do more of a clinical side and see patients that way and not do procedures. So it's definitely something that we work hand in hand with the PAs, NPs that are part of our team. No problem, John. Okay, so let's see. So a patient's crashing, they're calling IR because, the medicine team or the emergency department team has evaluated this patient. They clearly think that an IR intervention might be indicated. So that's our job as interventional radiologists to decide, is there something that we can do to help this patient? And then here we get to the PE, okay? So it's a STAT, which just means, right now, pulmonary embolism case. So if someone's coming in from the emergency department and they have evidence of a pulmonary embolism, that's something that, given certain criteria, we treat in interventional radiology. And here we are. So I'll give you guys just a minute. I know I'm going a little fast to look at this. And if someone maybe wants to tell me, so I'll give you a hint. These are the lungs, okay? This is an artery. And this is another artery. And this, like we talked about, is, the fancy term would be a filling defect. It's an area that doesn't have contrast. So I guess my focus question would be, do we know what artery this is? I'll give you guys a second to answer on YouTube Live. Yeah, okay. Amara, you're on it. Okay. These are all I really appreciate, and I hope this isn't torture to have me wait, but I really love interacting, and there's just a little bit of a delay between the two. Let's see, Amara, Shukri, Jonathan, Sentambuli, that's a really nice name. That's really interesting. Shuhani, And then Grace gets both of the main arteries. That's great. So this is the pulmonary artery, okay? So this is the aorta, and this is the pulmonary artery, okay? And then you have your right and your left main pulmonary arteries. And this is what we call a saddle embolism. And we call it that because it's straddling, okay, both pulmonary arteries. And this can be a big problem hemodynamically. Jungus, left pulmonary artery. Yeah, so this is something that goes into both the left and the right, and then, you know, and the main. It straddles both pulmonary arteries. And I'll take you through this. So, this is a clot that's similar to the case we showed before, right? So this is your vessels that you have, your veins that drain your legs, and then they come together and make your inferior vena cava. So it's kind of like we talked about. There's many things that predispose people to clotting. Things like immobility. You can imagine if you're laying down and your blood is not, you know, actively being pumped by your legs that are walking and moving. You have more what we call, you know, stasis, and you're slower. And then if your blood's moving slowly, you know, blood's moving slower in your veins compared to your arteries anyway, then you have you have a higher likelihood of forming clots. So you have a clot here, then your embolism. So it's broken off from that clot, from that thrombus. Now it's traveling. So we call this an embolism. Travels through the veins. So this is blue deoxygenated blood that's going back to the heart, that's about to enter the right heart circulation. This is something I definitely didn't know and appreciate when I was, you know, in undergrad and more focused on the molecular, you know, mechanisms of things. But this is just kind of basic physiology. So it goes to the right heart system, and then so that's your pulmonary artery that then's going to put that deoxygenated blood out to your lungs to get oxygenated and come back to your heart to then go to the rest of your body. So if it gets lodged in your pulmonary artery, or both pulmonary arteries in the case I just showed, then you have issues oxygenating your blood. And you also have issues because it forms pressure on your heart, because that blood that's trying to go into your lungs freely and get oxygenated can't, because there's something in the way. So I'll wait just a second here and see if anyone has any questions about this, because this is something that, you know, if you're interested in medicine and are in the hospital, so many different teams: medicine, sometimes surgery, interventional radiology, emergency medicine, pulmonary medicine, vascular surgery. We all know about these. I mean, everyone knows about these, but we're all kind of part of an interdisciplinary team that can treat these patients. Okay, Zoe has a question. Is this why they put compression socks on post-surgical patients and patients that are immobile? Absolutely. So there's actually, you know, rules in hospitals about putting on compression devices. If you've seen them, they literally squeeze your legs as these patients are in bed recovering and can't walk around or aren't likely to be walking around. It squeezes those legs and mimics you walking in a way, and so that your blood is not static, so that your blood is continually moving and not clotting. In terms of compression socking, that's a little bit of a different discussion, but it all has to do with the veins of your legs and making sure that the blood is moving from the bottom of, you know, your calves, your thighs, back to your heart in a manner that is appropriate, and so they don't clot. Where does the blood clot begin? Can it begin from anywhere and travel to the lung? Okay, that's a really good question. Really, the ones we worry about are the clots that come from your legs. Those are the biggest veins, okay? And those are the ones that, if they end up in your pulmonary arteries, are going to cause you to have, you know, clinical sequelae. So while you can definitely get blood clots in your arms, okay, so there's veins that go, you know, just like you have the legs, you have veins that drain, you know, both of your arms. If you get clots here, you could absolutely get swelling of that arm, but it's much less likely for that, which can cause problems and long-term, you know, outcomes and problems with functionality, and it's very uncomfortable to have a swollen arm. But those aren't as likely to cause a pulmonary embolism, not nearly as likely as the big veins of your lower extremities. Let's see. Are older people more predisposed to pulmonary embolism? I think so, because they carry more of the comorbid conditions. So there's many things that predispose you to pulmonary embolisms. Females are more likely to get it. The estrogens can be prothrombotic, okay? Immobility, being obese, having cancer, you know, you can think of like, you know, obviously very different than coronavirus, but you have a lot of inflammation and those you know, cytokines, if you've heard of cytokines, or things that travel around that wake up your system to, you know, respond to an invader, respond to cancer, respond to a virus. Those things also, unfortunately, make your body more prone to clotting. Okay, I'll keep going. But yeah. So this is a pretty morbid diagram, and I've really touched on this. And this is more so just to know that this, you know, this physiology is very complex. So I mentioned, right, you get this increased pulmonary vascular resistance. That's a lot of words. Really what that means is that you have a clot and blood is trying to go out to the lungs and become oxygenated, and you can't. Okay, so your right ventricle, so the right side of your heart, becomes dilated. Normally your left side's much bigger. Your left side is what pumps things to your, you know, your entire body, the oxygenated blood. Normally the right side is a lower pressure system. The right ventricle is smaller. But if your right ventricle becomes bigger than your left ventricle, and this is something that people, right when they come to the emergency room, if there's concern for a pulmonary embolism, they can ultrasound the legs, look for clot, and they can also do an echo, take a look at the heart, and see if that right ventricle is bigger than you would expect. And that can clue you in even before you get a CT scan that makes the definitive diagnosis that you have an issue with that pulmonary vascular resistance, okay? When you get rid of the clots in the legs. So Sarah's asking about the management of patients. And it really depends why they got a clot. And this is actually, you know, something that we talk about a lot. How long do people stay on anticoagulation after you get an event like this? And it really depends. There's a reason you got that event. For example, you were acutely ill, or you had a catheter and sometimes catheters can cause clots. Well, if there's a reason why you got the clot, often you don't need to be anticoagulated for your whole life. But if they can't find out a reason, or if they think that the reason you got a clot is because there's something to do with your genetics, or you know, something that you're going to carry with you for your entire life, then those patients are much more likely to require lifelong anticoagulation. Okay, so I'll take you through this case, and I just love this case. I hope that you guys can appreciate how cool this is. So this is just another example of a saddle embolism. It's not the identical one I showed before, but it is absolutely in both sides of the pulmonary arteries, the main pulmonary arteries. And they using catheters through your veins, and you know, here that looks like they're coming from the veins near your groin area. They go up with this catheter, and this is actually a pretty big catheter, and they quite literally suck this clot out of your lungs. And then you can take a picture after, and you can prove to yourself that in fact you have much better perfusion of both of this person had bilateral disease, and you literally get out these huge goobers that could be pulled out that are causing all of this vascular resistance, all of this, you know, hemodynamic issue. You pull them out, and the patients can quite often become miraculously improved in a very short amount of time. And I'll wait to see if there's any questions about this. Okay, and I'll answer this. Shuhani, she asks, if the case of clots is genetic, can young people also get clots at a young age, like adolescence? Adolescence is very young, but it's definitely possible. So patients who, you know, I can think of off the top of my head would be patients who have, exactly like you said, a genetic condition that predisposes them to clots. So there's different mutations you can have in your clotting cascade. You'll learn about these, it's, you know, but there's mutations that they test for that make you more likely to clot. And I would say I'm absolutely sure there are, teenagers and adolescents who have had these these types of problems, albeit it's predominantly a disease of adults. What are those things you called the plugin? These would be called, you're right, goobers is not the right word for these. These are clot, let's just call them what they are. They're clot that was in the pulmonary artery. So, you can get these embolisms that go to your lungs from your legs, let's say, but then as, more blood sees these and you get more increased vascular resistance, these actually can like propagate. And as they travel and propagate, you get more and more clotting. They can, they literally form. And actually the next picture I have, I believe, is, okay, so this is like literally, this person had bilateral clots. So this is, if you can imagine, like the pulmonary arterial tree. And this is someone who had such extensive clot in both lungs, and they pulled it out and they just kind of cutely configured it as roughly how it came out of the patient. And yes, so they are this big. So it looks like we have a measuring tape down here. It's 15 cm. Yeah, so that can kind of give you a sense of scale. But, if you think about it, your lungs and your thorax, you have these vessels, and you have, your main ones are here, but you can imagine that there's centimeters upon centimeters of clot that, if you have the right devices and the right, setup, you can actually be very successful in removing a lot of this clot. This isn't to say that this is how you treat every pulmonary embolism. I don't want that to be a take-home point. This is just, it's a newer technology, which is super cool that IRs are the ones who are using this and pretty much exclusively. And this is something that back in the day, before this technology existed, aka like 10 years ago, 5 years ago even, someone maybe with the clot burden like this would actually have to go to surgery, get their chest cracked open to remove these clots. And while those patients might very well recover and do just fine, as you can imagine, if you can spare someone a sternotomy or a big invasive procedure like that, and you can go through using tubes and lines and catheters that are about this big going through your groin, that's it's something that it has been making surgery for this type of issue less common. When you pull it out, where does it come out? Such a good question. So literally and I'll show some pictures later of kind of the room setup and how this looks, but you have the catheter, and you have tubes and lines that go in to the vein. That's a big vein that's located, let's say, in your groin. And then you go up that central vein and you go and get this. And when you attach a catheter, the catheter has big enough that it can suck this out. And there's different devices, but all these devices, use suction, and then it sucks it out and it puts it in a canister. And then you look in that canister and you shake the canister and you say, oh, that was a good one. You got a lot of clot there. So it essentially comes, if you think of it as like the fanciest vacuum you've ever seen, the fanciest, most life-saving vacuum you've ever seen, that might be a way to think of it. And then there's another question, how long does it take to get these clots out? It really depends how stuck they are in there, if the patient's stable enough to, come down and actually have this be, an option. It really depends how hard it is to navigate the vasculature. Sorry, in the vein of being a clinician and being a clinical specialty, I'm getting some questions from my bosses right now about studies, but we're all good. How do you maintain the shape of clot? I mean, it's really, the clot is, think of it like, memory. Like if you took something that's bendable, that when you bend it, it stays in that shape, even if you tried to unbend it. At the top of my head, I can't think of a good example. But it's essentially just taking the shape of a vessel. And if you imagine a tube and a big vacuum and you're sucking it through the tube, that's kind of how then it goes through that tubing and ends up in the canister, more or less in the configuration that it was inside the body. Okay, I think I'm gonna move on from this. You guys all have amazing questions. Okay, so your beeper goes off again. So I'm kind of simulating what a crazy, crazy day would be in a multi, specialty interventional radiology practice at a big, big hospital, okay? And here we have a stroke, okay? We're leaving the lungs. And so these are just cerebral angiograms of someone who, you know, I won't go into details, but you can appreciate on the left here, they're missing vessels in this region. And why is that? There's a clot somewhere, okay? And that clot is causing a stroke or is bound to cause a stroke. They're having stroke-like symptoms. Part of their brain is dying. Part of the brain might be salvageable, but you need to open up that blood flow as soon as possible to save that part of the brain. Oh, and really quick, Sophie's asking, are patients awake for this procedure? This applies to this case as well as the pulmonary embolism case. Often, yes. So there's risks involved in intubating patients. And because this is something that, you know, it's not open surgery, you're really using very small techniques, and really most of it's inside the vessels itself. It doesn't necessarily hurt. Patients can tolerate these procedures awake. And sometimes, depending on the hemodynamics of the patient, it's actually advantageous to have the patient awake and either mentating in the case of a stroke, or just awake and not under anesthesia medications, very strong ones that you would need for general anesthesia. And so, yeah, so we have the carotid coming up and going into the cerebral branch. I see we're talking about this stroke case now in the chat, so we've caught up. So this, you know, honestly, we can think of this as very similar to the PE case, very different organ system, very different pathology of this patient. But this is something that, you know, as a interventionalist, you would be able to treat if you have specialty training in neuroradiology or neurointervention. Okay, so and just to show you, there's a clot, right? There's a takeoff, there's a step off, right? That little, you can imagine a small kind of goober like I showed on the prior slide. And then when they go in and using similar techniques to what I, you know, grossly described, but at a much smaller scale and different devices, but the same idea, you remove that clot, you break up that clot, you suck it out, and you then regain perfusion to a large part of your brain. So these are things before these devices existed would quite often be fatal. Yeah, Justin, not really any nerves around the vessels so they can be awake. Yeah, you're exactly right. So you're, you know, while you're fine touch and, you know, if someone slices off your finger, you're gonna really feel that. Having, you know, manipulation and things in your vessels inside your body, it's a different nervous system, it's different sensations. And while patients can usually feel what you're doing, regardless of the procedure in some way, whether it's some pressure or, you know, a feeling they've never felt before because they've never had catheters in them before, usually it's not entirely uncomfortable. And this imaging is like, we can call this like an angiogram. Okay, so this is it's using like the same principles as CT. It's like ionizing radiation and contrast using, but these would be, you know, examples of angiograms where you're looking at the contrast going up and seeing where the word we would use is opacify, to see what opacifies, to see where the contrast is going. And then Aspen's asking, where do we perform these procedures? I'll get to that. Okay. So I just showed you some two like pretty crazy cases in my opinion, and really cool that we get to be a part of those cases. But interventional radiology also does a lot of good in ways that, you know, in situations that can be more scheduled. And I don't want to not talk about that. So fibroids, they are, you know, affect, you know, only individuals who have a uterus. Okay, they're you know, outgrowths of tissue, and they can be in a variety of areas within the uterus. And long story short is these can cause problems with bleeding. They can be uncomfortable. They can be bulky, and they really affect the quality of life of many women who suffer from them. You know, sometimes patients even get anemic and have blood loss and faint and you know, it's as though they are, you know, bleeding out you know, from anything. This really can be hemodynamically significant, and it can also really affect the patient's quality of life. And so we have a way of treating these and keeping the uterus intact. And that's really important in the situation of a patient, let's say, who still wants to have children. So this is something that we call uterine artery embolization. And it's exactly what that's exactly what the name says. So essentially what this is where you, you know, embolize meaning you put in something that would stop the flow. So while an embolism can be a bad thing if it's in your brain or it's in your pulmonary artery, sometimes you actually want to stop the flow of blood. and put in an embolic to get rid of something you don't want in your body. So that would be the case. So you can see in this just pictorial diagram, this is someone who using, just a small nick in the skin in your, femoral arterial area here. This is also something that can be done through the wrist, just to let you know. You gain access, okay, and then you really using what can some people compare to, playing video games. You're twisting, you're turning, you're using different, wires that have different stiffnesses to get into the vessel that you want. And then once you're there, you inject these particles, and these particles interact with the clotting system within your body, and they clot off those vessels, and those fibroids shrink down significantly or go away. And I'll wait for some questions because this, I know we're totally changing gears here. Okay. I think for the sake of time, I'm going to move on. The questions might catch up, but I'll keep going. Okay. So in a similar way to treating a fibroid and using catheters and wires, we can treat cancer. So this is just, let's see. Can you explain what a fibroid is? Noelle. Yeah. So I'm not sure if that question was, it's essentially, a growing, I apologize, I might not get this pathophysiology exactly correct, but essentially what they are is they're like an abnormal outgrowth of tissue that's located within your uterus. They're not cancer, okay? It's important to differentiate. They're a benign entity, but they can be, your uterus is a muscular and soft tissue, organ. And if you have, parts of it that get bigger, hypertrophy, and, form a mass, it's not a cancerous mass, but it's a mass that you can, feel that causes it to, feel heavy. And those masses can, then, be compromised, and you can bleed from them. So, yes, I hope that answers your question about, and okay, Helena must be reading my mind. Helika Herban, can you do similar procedure for tumors to cut off blood flow? Yes, and then some. So the answer is yes, and I will go there. It says, and to Tuna Gray, how familiar are OB-GYNs with this procedure? Yeah, so it's they're familiar. So there's actually a very recent clinical trial that came out that was looking specifically at the differences in outcomes between patients treated with uterine artery embolization and surgical treatment for fibroids. So you can either get a hysterectomy or you can go in and get a myomectomy, where they essentially, take out those fibroids from the inside in a, surgery. And so, yeah, so it's definitely something, we're aware of what the other specialty offers, and there's, nuances and I think differences of opinion on who is the best candidate for which type of procedure. But it's definitely something that, if you personally have questions about, or people in your family have questions about, it's newer. Interventional radiology itself is a newer field. So if you have questions about, this as it relates to OB-GYN and how this fits into the clinical management of patients, it would definitely be an appropriate thing to ask an OB-GYN, or if you're on a clerkship or shadowing an OB-GYN, let me know what they say, because, we do a lot of them. There's good data to support doing them. And it's definitely something that only, an interventional radiologist would do, similar to how, an obstetrician gynecologist would be the one who would be performing the surgical treatment for fibroids. And Sophie, how do you tell the difference between a cyst and a fibroid? Yeah, so that's a really good question. And so, and really, you want to know, if it's a cyst, is it a fibroid, or is it potentially cancer? So uterine cancer. So an MRI, well, the long story short, an MRI is something we obtain in these patients, and that gives us a lot of, structural information, as well as information about, the density, or the components of the the structure, okay? So we would be able to tell if that structure is something that's more fluid-like, more cyst-like, or more solid. We'd be able to tell if that structure is a, nice circle and looks like a fibroid, or is there some irregularity? Is it kind of extending and invading into surrounding structures where you would say, I really would, we probably want to biopsy this or think about surgery if it looks like something like more like cancer. And so back to Helena's great question. Yes, this is case 5 of the day. So this would be a targeted cancer treatment. So this is probably maybe too hard of a question, but let's think about, and this is a type of angiogram, okay, where you can see the contrast, you see a tumor. You can see here, this is the right side of the body. I'll give you a hint and let you know that this is your diaphragm. Does anyone want to venture to guess what organ we might be in here? I'll wait for you guys to catch up on YouTube. Yes, Jonathan Bailey, you got it. Liver, that's exactly right. Yeah, Noelle and Jonathan, you got this. Liver, yep. Kidney's not too far away. So yeah, this is the liver. So this is most likely a hepatocellular carcinoma. We don't need to get into the details of that, but this is a big tumor and it's located. Yeah, you guys are all doing well. Gosh, you guys should all be radiologists. Thanks for answering my questions. This is a tumor, and for reasons, that are, somewhat advanced, you can really tell this is a tumor. Okay, like this is not how, you might just have to take my word for it, but this is not how a normal liver tissue should look when you're injecting it with contrast. So you can really actually see an outline of a tumor with some irregular vessels, and this is a tumor that's very, pretty centrally located within the liver. And so without catheters, the options might be slim. You can go on systemic chemotherapy, and that can help a little bit, and more as more advanced chemotherapies come out. But really, a mainstay of treatment for patients, especially patients who have, let's say, a more central or just one lesion that really is known to be cancer, is compatible with cancer, and you want to treat, interventional radiologists can absolutely treat that. And so you can not only put, let's say, these embolic particles, but you can also put in chemotherapy itself. So then these patients suffer much less side effects from this, because you're putting that chemotherapy, or in some cases radiation, exactly where you want it to be. So similar to how I showed that picture of the groin going up and navigating through the body, you can do the same thing either through the groin area or through the wrist. You navigate through the central vessels, the central arteries of your body. You select the vessels that lead to the liver, and then you further select the vessels that lead to the tumor, and you can just exquisitely target these tumors and get follow-up imaging and prove to yourself that you've actually treated the cancer. Yeah, and so there's a question about what is contrast. That's a really good question. There's lots of different kinds of contrast, and it's a material that it's a liquid that when you use X-ray beams, okay, you can see the material because it's very dense. So it's essentially like taking, I don't know, you can imagine, let's say if there's like an X-ray, you have your watch is full of metal, okay? You can see a ring, if you've seen an example of those types of X-rays, those are like metals that the X-ray beams cannot go through, so they show up as dark on the images. So that's exactly kind of what we're looking at here. It's a very dense material. Okay. I got so many good questions. I'm going to keep going because I can't believe we're almost at an hour. I hope this has been enjoyable, but I'll finish up here in a minute. So this is just a portacath placement, and this is something that you guys, if you, I of course sincerely hope not, but if you've ever had a family member or a friend or know anyone who's had cancer who needs systemic chemotherapy, you might have seen that they have a port in their chest. And what this port is a way for you to get chemotherapy, administer it, so you don't need to keep getting stuck with an IV, and the provider can directly administer chemotherapy to a very large vein and the larger the vein in general, it's safer to administer more toxic drugs. You don't want to administer them in your very small veins. It can cause issues with those veins. So this is a procedure that we do. We, oncologists and all of the specialties that treat different types of cancer refer us patients, and we, play a very small but important role in their care in terms of putting in that catheter, usually as a patient has a new diagnosis of cancer, to then treat that cancer later with chemotherapy. So this is a central vein, okay? Actually, we'd stick one of these veins, sometimes a vein up here, or, there's different ways to stick the vein using ultrasound guidance. And then there's a catheter. A catheter just means tube, okay, that goes and it dangles into the central vein in the center of your body. And that's where you would administer the chemotherapy. Okay. So where are these procedures performed? I've seen some questions on YouTube Live about that, and let me show you. So this is an angio suite. I mean, if this picture isn't cool enough to convince you to maybe consider a field in interventional radiology, I don't know what is. Normally we don't have necessarily purple lights, but sometimes we do turn down the lights because it helps us see our images better. But this essentially is our camera, okay? It's like and here is the patient, okay? And so we drape the patient. If you've ever been to a surgery or seen surgery, the room is essentially looks similar to that, but you have this camera that you are constantly adjusting its angle, where it is, going up and down on your body as you navigate exactly where you want to be and which organ system you want to guide your catheters towards. And this is, someone who's probably holding a wire or a catheter who could be injecting contrast, and that, it's a little hard to see, but you can see this contrast material here that's, filling up a vessel, and you might be wanting to go into that vessel to treat a variety of things like we just talked about. And then this looks straight out of a sci-fi film. Yeah, I mean, honestly, I find myself even, I've done a lot of cases. I'm still very, very junior. Okay. But I still find myself, in the rooms playing with it, not playing, but, adjusting the technology, setting everything up, pulling my big screens over. And it's exciting. The technology is cool, and you can do so much through such a little hole in the groin or hole in the wrist. And I just find that to be fascinating, because then you get all of these, nice tools to help you do a lot of good through a very small incision. So tools we use, I've alluded to some of these. So we talked about balloons. So here's a balloon. This is an example of a stent that could go, in an artery or a vein if you want to, hold that vascular structure open. We have needles that we use to access the vessels with ultrasound guidance. We have plugs. Let's say you have like something that's bleeding and you want to plug it up because they're bleeding, even, hemorrhaging to death. You put that plug in, and they come in a variety of shapes and sizes and textures to plug up that vessel that could be bleeding. And these are catheters that you use, as you can imagine, to select different vessels, different small vessels throughout the body. Just to answer some questions right now, how long do most IR procedures take? It really depends. So putting in something like a port can take as little as 20 minutes, depending on, how the patient's anatomy and how experienced you are, how many years you've been doing them. But then there's cases that are very complex. Let's say something I didn't show, but like a bleed, an internal bleed. Sometimes it can be very challenging to find where the bleed is coming from. And it's very important in these patients to find that spot. So you can spend hours, honestly, looking for different vessels and trying to inject contrast into areas to look to see where the pathology may be. And what's the longest procedure I've done? I would say the longest procedure I've done was probably maybe 4 hours. And really, a lot of that time is spent using different techniques and wires and different approaches to, this case was to treat someone who had leg ischemia. So without getting into too many of the weeds. They essentially had really bad atherosclerosis, so like, crunchy small vessels, and they're not getting enough blood flow, enough oxygen to their feet, and these patients can end up with amputation. So interventional radiologists as well as vascular surgeons will do very advanced interventions to try to reestablish blood flow to the foot, and those can often involve accessing many arteries, which means putting in a needle, wire, catheter into many arteries, and trying to decide where do you want to connect, and how is this blood flow going, and how do we want to balloon from top of the leg to bottom of the leg? What balloons do we want to use? What size stents do we want to use? Those are all things that take up time and are part of the problem solving and the fun and the challenge that comes along with this field. Let's see if there's any other questions. Can you talk about your pathway to med school? Yeah, gosh, I did have one slide on that, but let's see if okay. So this isn't applying to residency, but I should have had I do have a slide on that. But while I'm on this slide, I think a lot of the things that apply to residency can apply to undergraduates. And what I would say is, my personal pathway in in undergraduate was very focused on lab research. And everyone says, join a lab. I loved my lab research. It was not an interventional radiology. That said, there's no reason why an undergraduate couldn't get involved if you're affiliated with a medical center in interventional radiology. But essentially my pathway to medical school was guided by so talk about your pathway to medical school. Okay, that kind of gets into my childhood. So I will say, let's talk about like mentors, right? So my dad is a physician, so he gave me, advice growing up about, just what medicine was about. He is a surgeon, and I knew a little bit about it, but he definitely, told me what pre-med classes were. Told me, working in a lab is probably a good idea, and that's something that he did. That he found a lot of fulfillment from when he was in college. So, and it's more than okay. And if and when you don't have close family friends or parents in medicine, but I would just say the biggest thing you can do to help yourself would be to find a mentor that's invested in you, that can help you, that can guide you to make these decisions. Research, whether it's undergraduate or in medical school, in field related to interventional radiology is paramount, especially for medical students looking to go into interventional radiology. Something you can do at any age is go to these conferences and just broaden your horizon to what an interventional radiologist looks like. So, I went as a second year medical student. I really didn't know anything about interventional radiology apart from the little project I'd started to work on. And it was amazing to go and see kind of the different sessions and how excited people were to connect with, old mentors, old friends. So those would all be, I would say, small things as a undergraduate or medical student you could look into. In terms of shadowing, that's probably more of applicable to undergraduates, because once you're a medical student, you're a bit more involved in the hospital process. But I would say, be strategic about your shadowing. Shadowing can be, can take a lot of different shapes and sizes, but find a good fit. And I know that's easier said than done, but I would say in college, if people, interventional radiologists are super approachable. It's a really cool field. It's a new field in terms of it being its own pathway that's integrated pathway with diagnostic radiology. So I can't imagine anyone would have, and if you want to reach out to me, if you're at an institution and you don't know, maybe if there's someone you can contact, ask me, because I might know, or I might know someone who would know. Do some shadowing just to step foot. You'd be able to step foot in a theater or IR suite that looks similar to what I just showed you, and just take in for what it is, what the procedures looks like, because you can never be too early. It can never be too early to have exposure to this field. And I would say, in terms of medical students who are applying to residency, one of the biggest things that residencies look for is someone who has a real understanding of what the field is, because it is very, very specific. They want to make sure that you're going to be happy in the field. And part of that is knowing what the field is all about, so that you've had a good appreciation of going to all different types of cases, maybe doing an away rotation when those come back after Corona. So those would be things I would definitely advise to do. And yeah, that's a bit general, but I would say, let's see if there's any other more specific questions. In terms of gap years, yeah. So I'll finish my slides and we'll see how much time we have left. But yeah, and one more point to the medical students. Let's say this is your first of hearing about IR. Let's say you're first year, second year, even a third year. And maybe, if I should be so lucky, I'm the first one to kind of show you what this is all about. That's awesome. And you should definitely seek more out. And it's never too late necessarily to get involved, but definitely just jump in and go to cases and see if you can get involved in research. And really, I lost my train of thought, but where I was going with that was approach all of the specialties. Is what I did is I approached all the specialties. I rotated through as a medical student as something that, could I picture myself happy here? And quite honestly, I could picture myself happy in a lot of different specialties. And I had exposure to IR in my, pre-clinical years. So I knew kind of what, I knew a bit about what they did. So when I rotated through surgery, medicine, OB-GYN, there was, of course, super valuable experiences. And I played it, a game with myself. Okay, do I like this more than IR? Do I not like this more in IR? Like, be honest with yourself. This is the rest of your life and what you have to do the rest of your life. And I just personally made the decision that I was still, honed in to going into IR. But yeah, so the earlier the exposure, the better. Sorry, a lot of different talking. Hope some of that was useful. I think I'm almost through my slides. Okay, I'll fly through this, but at a minimum, it's it's a bit of training, but to be honest, everything's a lot of training. Even if you go into something that's 3 years, there's probably a 3-year fellowship that is, something you should, that most people will do after anyway. So this isn't something that's a fast training, but you do it because you love the specialty, not because you want to get done soon. So you would need the 4 years of undergrad, 4 years of medical school. I saw some questions about intern year. So I did a surgical intern year. I found that super useful because we deal with a lot of surgical patients and post-surgical complications or post-surgical issues that are unique to post-surgical patients, transplant patients, specifically liver transplant patients. So you do an intern year that's separate, and then you do a 5-year integrated path with diagnostic interventional radiology. The general split is 3 years of diagnostic with 2 years of interventional. And that's kind of, when I say it's kind of a new specialty, what I mean is only for the past 3 or 4 years has this actually been an option. In the past, you would apply to radiology, and then once you're a couple of years into your diagnostic radiology residency, you would then apply for a fellowship. Whereas here, it is a integrated program. And I won't go through this diagram, but if anyone wants to screenshot this for a second, or I think this might be up on YouTube, this is essentially what the, as we're transitioning into being a fully integrated specialty, these are the different pathways that that you could take to enter this specialty. This is my, I think, penultimate slide. So what could your life as an IR look like? First of all, it's going to be awesome, but it could be highly variable. I showed some really, acute, cool cases that would primarily be done at a large medical center. So you can do that. You can work there, and similar to where a lot of the training hospitals are, but you can also go into private practice, and private practice, you can work at a trauma hospital, you could work at a non-trauma hospital, each of which will have different mixes of cases. You can work at an outpatient center primarily. So that would be doing cases that are essentially all scheduled or elective even. So you could do a lot of the varicose vein work, or you could place porticast, or something I didn't touch on, but is a decent part of the work we do would be working with patients who are on dialysis, who have fistulas and grafts. We do a lot, while we don't create them ourselves, we do the majority of the troubleshooting, or we do vascular surgery does as well. So, but I would say both of our specialties do a lot of the troubleshooting. If they clog, if they stenose, if they have other issues, need to be taken down. And then just to touch, you can even further subspecialize within interventional radiology, which sounds probably, I mean, even to me as a second year, it sounds so far away, but you can work with primarily kids. You can do an additional year of training and do all neuro procedures and do, aneurysm work and have strokes be your mainstay. And there's even, people who, like I said, who do like the vein work. Some of it's considered cosmetic. That's a whole nother kind of field that, if you go to the national meeting or even Google, interventional radiology cosmetics, you'll definitely find information there. And you can, last but not least, you can, I love doing procedures, but if there's ever a time in my life where I want to do more of a diagnostic radiology job, you do get board certified in both. And so that's always an option moving forward, depending on your work environment and where you're hired and what they need from you and what you want to do. And okay, that was my second to last slide. So I really hope that this was an enjoyable Friday mid-afternoon activity. I really enjoyed speaking with you guys. Your questions and answers were absolutely amazing. I mean it when I say please reach out to me if you have any questions. That's also my Instagram that it's not really a radiology Instagram. It's more of an Instagram for, clinical trial news as it relates to like current events, because I just am having fun with it. But anyway, please reach out if you have any questions, because it's just, I'm so happy in this field, and I really hope you guys consider it.
Thank you so much, Dr. Watchmaker, for presenting for our web shadowers. We loved how interactive and informative your presentation was, and we really appreciate how you answered everyone's questions. So we were honored to have learned from you. Everyone, please make sure you check out her socials to learn more from her. Her Instagram is at Dr. Jenny MD PhD. Additionally, the link is now posted in the chat, and it'll soon be in the description of this video. So again, thank you so much, Dr. Watchmaker. We really appreciated it.
Yeah, of course.